Hello and welcome back to the Polaris Travel Health Podcast. Thanks for tuning in with us again this week. This week, Jaden and I will be discussing tuberculosis.
Yeah. Well, thanks for having me back. It's been a little while since we've recorded, but tuberculosis is actually second only to HIV and AIDS as a single agent cause of death. However, in the developed world, I think we tend not to consider TB in our evaluation of deadly diseases because we don't discuss it as often as we do other types of things. So, what is tuberculosis and how is it spread?
I think those points you just made, Jaden, are actually really good. We don't think about tuberculosis much. But yeah, let's start with the basics. It's a bacterial infection and it's caused by Mycobacterium tuberculosis. That's the scientific name for it. And it's primarily spread through inhalation of droplets like coughing, sneezing, that sort of thing. And yeah, it's an incredibly common illness, and about a third of the world is infected with tuberculosis bacteria and are potentially at risk of developing clinical disease. Most people don't even realize that they're infected. And we also know that tuberculosis plus HIV is a really lethal combination as well. But I think the thing about this is, yeah, it's certainly something that is significant. Again, not so much here, but in other places.
Right. So where is tuberculosis kind of the most common in the world?
Well, I think you can break it down and talk about developing countries, Asia, Southeast Asia, South Asia, Africa, I think even into the Western Pacific areas as well. But, I believe, again, Jaden, you were doing your advanced research for me, and you actually came up with a nice little list of countries here. And yeah, like the ones listed here are India, Indonesia, China, Philippines, Pakistan, Nigeria, Bangladesh, and South Africa. So I'd say that, those are certainly countries where it would be on my radar screen. And when you talk about Canada, like I do sort of want to go over a little bit about the history of tuberculosis in Canada. It was certainly at one point in time, it was a thing. Like people got sick and died from tuberculosis for sure. It happened in Canada. Right. It happened in Western countries all the time. Now we're so far away from it at this point that we don't have a lot of the stories that sort of what happened. But even there were these places, and I don't know how familiar you are with these, Jaden. They were called like sanatoriums, and what they basically were, they were places where people with tuberculosis would go and they'd get lots of fresh air and they'd be sort of separated out from society. And you could be there for really lengthy periods of time, convalescing. Right. And, then we came up with antibiotics and with antibiotic treatment, tuberculosis in Canada has become not a sort of endemic disease anymore. It's still present in some communities in the north in Nunavut, that sort of location. But typically speaking, most of the cases we see now are imported in either from travel or from people that have moved to Canada who have the latent infection.
Right. So kind of on that, I wanted to kind of chat more about the latent versus the clinical phase of the disease, where you can kind of be infected with the bacteria but not know that you have tuberculosis, and kind of what causes it to activate aside from, say, having something like HIV.
It's not always completely clear as to what could cause the latent infection to activate. You're right, being immunocompromised, having HIV, certainly those are considerations. But sometimes it's not always super clear cut on what a trigger factor is. And, it's entirely possible that many people who have the bacteria dormant in their system will never get sick. In fact, really? That's common. Like that would not be unusual that you would get it. It's not something that's guaranteed that it's going to get you like in a year or 10 years or whatever. You could have it in your system, basically for the rest of your life, and it can never activate.
Right. Can you spread it when you have the latent disease?
No. So it's basically really just dormant inside you because you need to be having essentially that the bacteria and, you're coughing it out, sneezing it out, that sort of thing. So just being around somebody who has latent TB is not a real risk factor. If it was, be very bad for all of us, because even here in Canada, there's no shortage of people that probably have been exposed to the bacteria at some point in the past. Because in a country like Canada, like we have a lot of immigrants who have come from other countries and were born in other places, and they're here now, so their exposure from the past could, if they were able to spread, it would be a real problem.
Right. So it's kind of like shingles in that sense, like it's kind of just waiting inside of you to make you sick, but it might not.
In a lot of ways, it would be similar, but I think the one difference right now is with shingles, you had chickenpox, right? Like most people,
right.
when they had chickenpox, they remember it. It's clearly something that was a thing, and then you get shingles potentially decades later. Well, then we can always say, well, remember you had chickenpox back when you were 10. But it's, sometimes you can run into a situation where people had a very subclinical, like a very low symptomatic response to chickenpox. But most people remember having chickenpox, at least in a general sense. But with this, there was no initial infection. You were exposed. It essentially is in your body, but you couldn't look back on that point saying, oh, geez, remember that time when you were sick? You were coughing a bit, and you had sort of the first infection of tuberculosis. That's not how it works.
Right. So when you do get into the kind of clinical phase where you do get sick with tuberculosis, what do the symptoms look like?
I think by far the most likely common symptoms you want to talk about are sort of lung-based, pulmonary-based things like, coughing, chest pain, coughing up blood, fever and night sweats, weight loss, fatigue. These are the most common things. That being said, tuberculosis infections can also happen in other parts of the body. I think there have been cases, and I'm not the biggest expert on all the details of some of the other versions, but I know that you can get tuberculosis infections, in your brain and in other parts of your body as well. So it is something that I know is a possibility. But yeah, when we think about the infections, by far the most common and the ones we associate with the most are the pulmonary, lung-based type things.
Right. So how you kind of mentioned earlier that there was antibiotics treatments. How do they kind of work, and kind of how long can it take for them to work?
Yeah, that's something really different about tuberculosis relative to some of the other types of bacterial infections that we have to deal with. Now, there are a couple different options, of course, depending on where you're at with do you have latent tuberculosis or do you have active tuberculosis? And that definitely changes things. So if you have latent tuberculosis and you're not really sick, but what you're trying to basically do is prevent the disease from activating later, usually the one that you most common take on this basis is one called isoniazid, and you have to take it for, I think at least a minimum of 6 months. So if that's more in the latent stages, if you have active disease, then you have to start doing combination therapy. Like usually you're looking at, a couple, 2 to 3 different antibiotics. And, generally speaking, you start talking about things like rifampin, and so these are not really particularly pleasant antibiotics to take. The side effect profile is not super awesome, but people will start to feel better relatively soon, within several weeks. But really, to completely eliminate it from the body, you're looking at 6 to 12 month course of treatment. So there aren't very many other infections that we deal with that you have to take antibiotics for this length of time. But yeah, it's that's what you're looking at here, and it's a very difficult bacteria to completely get out of your system.
Right. And is there kind of like a way to know that your body is kind of completely cleared the infection, or is it just kind of we're making educated guesses based on the length of treatment that you've taken?
Well, they do a lot of follow-up x-rays and checking. Like that's probably one of the things that you would really see, is that you be checking x-rays to see if there's any evidence of active disease. That would probably be one of the main markers. And I believe that there's also, you can do like a sputum test, like essentially a spit test. You spit or cough or whatever, put some of your something you expel from your mouth, and you put it in a container, and then they can culture it to see if there's active bacteria. So I think those are the two things that, typically speaking, I think are the most common ways of monitoring effectiveness of treatment.
Right. So kind of on that note, there are some forms of tuberculosis that have become drug resistant, right?
Yes. So right now, in these circumstances, you have to come up with different combinations of treatment and then longer periods of treatment. Like, I think you can be looking at, instead of looking at a 6 to 12 month period of time, like you can look at like more than double the time on that. And those are really tricky situations, but they are becoming more common right now. And I'll put it to you this way: tuberculosis is not something that you're going to be dealing with through your family doctor. Like, if you get in Canada, if you get tuberculosis, like, there actually is a tuberculosis clinic. There's one in Calgary, our part of the world here, and it's exclusively devoted to tuberculosis patients. So if there's ever a situation where someone was determined to be a person that needed tuberculosis treatment, or they would be referred to there, and they would be followed there during the course of their treatment.
Right. And is that kind of like drug resistance because of improper use of antibiotics, or is it just kind of like it eventually evolves past what we can do for it?
It's sort of a mixture of both those things. I think that, these antibiotics that have been used for a long time. They're not new drugs. And certainly with the number of infections, worldwide, and the use of them, one of the problems that you're going to run into is if you have to take something and you have to take it for 6 to 12 months and the side effect profile not so great, it makes it really hard to convince people to keep taking it. And of course, if you take it for a while, you feel better, and then you still take it for a while, and then all of a sudden you're like, oh, I've been taking this stuff for like 4 months and I'm done because I feel like garbage. That is a really opportune time for the tuberculosis bacteria to become resistant. And that's what you run into. And then even on that point, and I can tell you this because one of the nurses over at our clinic, maybe she's listening. Hi, Morgan. She helps us out at the clinic giving vaccinations, but she also works at the tuberculosis clinic. And one of the jobs at the clinic here in Calgary is that some patients, in order to make sure that they take their medicine, actually have to either come in physically to the clinic, or in the era of COVID, have to log in on Zoom, and they have to be observed. It's called daily observed therapy, where you basically have to watch the person take their medicine if there's a concern that they're not going to take it. So that's something that has to happen. And it's kind of almost like a similar vein to like people that are like on opioid treatments, like a methadone, where you have to basically, consume the dose in front of a healthcare professional. Well, this is the same kind of thing. And it's not necessarily for everybody, but certainly for some people that there's a concern that they're not going to take it, then those are the measures that have to happen.
Right. So kind of before we move on to talking maybe about some testing, some kind of like applications to our context, I did kind of want to touch on the tuberculosis vaccine, which I didn't actually know existed until I started doing the research for this episode.
Yes, it's a very strange vaccine. Everyone calls it BCG vaccine. It actually, I'm not even sure I'm pronouncing it right, but it's Bacille Calmette Guerin, something like that. Anyway, BCG vaccine is what we're going to keep calling it. This is a vaccine. Yeah, exactly. This is a vaccine that's given usually right in the first few days at birth, or within a day or two of birth, to infants in developing countries, especially in some of those high-risk countries. So really what ends up happening here is that in most Asian countries, in most African countries, this is a vaccine which is very standardly done. And the vaccine really helps protect kids under 5 from really getting some of the more dangerous, for tuberculosis, really some of the more dangerous versions, like when you start talking about disseminated TB in different parts of the body. It does definitely help with that. So this is something that is very common. We see it in other parts of the world. In Canada, we haven't given BCG vaccine. It's a really old vaccine. We haven't given it here for many, many years. That being said, in some northern communities, like in areas in Nunavut, where there are still cases of tuberculosis floating around, there is still some BCG vaccine being done in Canada. Theoretically, it's an available approved vaccine, but I've never seen it myself. I've never seen anyone vaccinated for BCG like that I've been directly involved with.
Right. And so it is a live vaccine then.
Correct, it is. So there's concerns about getting it if you're immunocompromised or if you're pregnant. We don't give it to travelers. That's not something that happens either. But it is, like I said, it is sort of an unusual vaccine in the sense that, we only really give it to little kids, and we really only give it to little kids if we're really concerned about, there being a high risk. Interestingly enough, Jaden, and this is not something we had prepped up in the notes, BCG vaccine is being used for some really unusual things right now. It's even been looked at as a COVID-19 treatment. And the other one, which I think is really unusual, is there have been some studies that have been done, and don't ask me to explain them because I will not even attempt to try. There have been some studies done where they've given people with type 1 diabetes BCG vaccine, and it seems to actually kind of sort of cure them. So, so this could be like a real thing. I don't think anyone fully understands exactly where we're going with on this, but there is some suggestion that maybe if you gave a type 1 diabetic BCG vaccine, like even if they're like an adult, that it could actually reverse the effects of type 1 diabetes. And like I said, I don't know much about it. I read a couple things on it, and I don't really want to give anybody any specific hope or anything, but it's just an unusual vaccine in the sense that they've tried some unusual things with it, and there seems like there could be other uses for it. So if, 5 years from now that they're somehow giving this to people with diabetes, you can say that you heard it here first.
Very true. We're ahead of the research here a little bit.
Way ahead of the curve on that. Yeah.
Okay. One thing I was going to ask you that I thought of while we were talking about that vaccine is, can latent TB be passed from mother to child?
I don't think so.
Or is that not a question that you would know the answer to?
I don't. My definitive answer is I'm not sure, but I don't think so. I don't know. That's a good question, and I don't know the answer to that. You got me, Jaden. I'm stumped on that one. You would.
I got you there.
Yeah, I would tend to think no, but I'm not going to commit to that answer. All right, we'll see.
Okay.
I'm going to be looking that up after we're done recording.
All right. Well, I sparked your interest for later.
Yeah.
Okay, so moving on, what does testing for tuberculosis look like?
There are really two different types of testing that we can see potentially for tuberculosis. There's sort of the old school tuberculin skin testing, and then there is this relatively new thing, and it's abbreviated IGRA. It's interferon gamma release assay. So IGRA is basically a blood test. So this is a very cool, accurate way of determining tuberculosis infection. The thing is that we tend not to do it very often because it's expensive. And I know here in Alberta, for example, to do that kind of testing, there is only, I don't know if this is still the case, but I went to a presentation a few years ago about tuberculosis. And with doing some of these blood tests like this, there's only a limited amount of tests that can be ordered a year, and they have to be ordered by an infectious disease specialist in tuberculosis. So it is something which is a very good test. And I know, for example, in the United States, it's very easily obtainable. I've had people tell me that they've gone down to school in the States and they were able to get the test no problem. But up in Canada, it's a difficult test to get through the public healthcare system. But
right.
Anyway, now that we've kind of talked about that, we can go over like the sort of the tuberculin skin test, which is probably the one that most people have had experience with that, and that's the one that certainly in our clinic we do a whole bunch of these. Really, when it comes right down to it, that's going to be the test we're going to most often see.
Right. Right. So that test is a requirement for people planning on entering certain kind of like practicum programs for like healthcare work and that sort of thing, right?
Yeah, exactly. The primary time that we see it is for someone that's starting a new job in healthcare or someone who's in post-secondary school and they need it to go on their practicum. So if you're in a healthcare aid program or a medical program or a nursing program, or for that being said, if you're starting a job, you're working in a care facility in a nursing home, a lot of times that a test like this will be requested. And sometimes we do them pre and post travel to if someone's going to a really high risk area. But realistically speaking, if you look at the numbers, they're mostly for school and then for work.
Right. So how does the skin test work? Like, what's the procedure?
Well, the skin test is an intradermal injection. So it basically just goes just underneath the skin. So what happens basically is the tuberculin protein is just injected, and it's like zero 0.1 milliliter. It's a really small amount, and it's injected usually like in the forearm area. And after it's been injected, then you come back in 48 to 72 hours, and then we basically look at your arm and see if there's been any kind of reaction. And what a reaction really looks like, the best way to describe it is it kind of looks like a big mosquito bite. So if you get the test done, and really it's more based on actually feel than on visual. You basically sort of touch the area and you try to determine whether there's a bump, and there can often be some redness and some bruising, but if there's no actual bump, then that's what we're looking for. And then when you start thinking about, how big does the bump need to be, usually the cutoff between what we would determine as being a positive test would be usually about 10 millimeters is what we're typically looking at.
Right. So how common would you say it is to find out that you have latent TB during this process?
It happens, I guess the way I would answer that is, how many positive tests do you see? And we do see certainly a percentage of people that have positive tests. Now, a lot of the people that have positive tests are not necessarily people that have latent TB, but here's the thing, and I don't think we've really talked about this yet, but if you receive that BCG vaccine, which we talked about, so you grew up in the Philippines, or you grew up in Nigeria, or one of the countries that we had mentioned before, the higher risk countries, and you received a BCG vaccine when you were a baby. One of the things that happens with the BCG vaccine is it can result that even years and years later, if you're getting one of these tuberculin skin tests done, that you can have a false positive result because of that. So very often, if we see a positive test, lots of times I think we can tend to attribute it to the BCG vaccine when they were a baby. That being said, if it comes back and the test is positive, the next step really is that you need to get checked out with a chest x-ray. And that's sort of the next step in the process. And then if the chest x-ray comes back and it's negative, which, if the person has no symptoms, then, lots of times it can be just sort of suggested that it's as a result of the BCG vaccine. That being said, if there is a concern it's latent TB, then that turns into a conversation sometimes where person can get referred over to the TB clinic, and then they could go on the preventative antibiotics for a period of time. So that's usually the process of what happens.
Right. So on that kind of note, how often should people who are working in healthcare kind of be tested for TB, or is it just kind of most often you're tested before you start working and then that's considered sufficient?
Well, I guess it's whenever your employer asks you, right? Generally speaking, though, it's usually something that gets done prior to you starting a job. And usually the results, if you have a TB test done, the results are valid for a year. That's the usual timing, because the argument is you had a tuberculin skin test and you had it done 5 years ago and it was negative. Well, that's great, but what have you been doing the last 5 years? Have you traveled? Where have you been exposed to someone who's had tuberculosis? So those are things that would basically render a tuberculosis test as being invalid. So you need to have that within the 12 months. So lots of times when I see students, they'll ask me, like, do I need to get one of these done every year? How often do I need to get this done? Well, a lot of times it just turns into, if you're starting a new course in school that requires a practicum, or you're starting a new job, then you might need it done. I had this conversation with a healthcare aid worker here a couple weeks ago, and we were having this exact conversation, and we were doing their TB test. So before they were going on practicum, and she said, well, when's the next one of these? And I said, well, really, if you finish your course and you get hired on, you get a new job, and they ask you to have one of these tests, you can, if it's within 12 months, you can just show them the result. But then if that's what happens, then you say work at that job for 3 or 4 years, and then you get another job offer at some other care facility, and they may say, okay, well, now we need to test you. So that would be most often how it works. There are some professions like respiratory therapy tech that maybe they need to be tested more often, like every year or so. But that's very much because tuberculosis and being exposed to coughing and those kind of patients, you're at a higher risk than you would be, for example, if you are, not in that area. Like I said, if you were doing more healthcare aid or, pharmacist or something like that.
Right. So is there anything else that you wanted to mention about tuberculosis, about the tests, or anything else that we didn't get to?
Couple things, actually. One thing that comes up somewhat in our clinic is about things called a one-step TB test and a two-step TB test. So a one-step test is basically what I described before. You come in, you get the little injection under your skin, and you come back 48 to 72 hours later, and then we read it, and then you're done. But a two-step test essentially is getting the test done, just like we mentioned, but then getting the test repeated 7 to 28 days later. So it's exactly the same process. You just have to do it twice, and you have to do the second one at least 7 days after the first one, but less than 28 days. Now, in Alberta, very few places require a two-step test. There are some situations for some workplaces, but generally speaking, unless you're going into respiratory therapy, we don't do two-step tests here. That being said, practically everybody in Ontario going to school in Ontario needs a two-step test. And the short answer of that is, I don't know why. Two-step tests, there hasn't been, I have yet to see a lot of evidence that points to the need for a two-step test, like, except for maybe higher risk people. And but again, it's like I said, you do what you're told. And essentially we've had lots of people come in that need two-step tests that are not even doing particularly high risk type things, like the not respiratory techs or anything like that, therapy techs, but they're going to school in Ontario, and Ontario basically requires it. So, again, you have to kind of read over what is requested of you. And if you have any documentation, hopefully the person, if you're getting someone to do this test, that they understand what you need to do. But I think people, if they see that, those dreaded 2 words, two-step, you need to make sure to be aware of that, because even from a timing standpoint, essentially that means you have to attend the place you're getting it done 4 times for the test, and then 40 to 72 hours later, the read, and then you got to come back in with a window of time and do that again 2 more times. So, we've had situations where people have needed a two-step test and they didn't realize they needed a two-step test, and they're moving to Ontario in 10 days. Well, that turns into a problem, because, then how do you schedule that out? So it's just something to be aware of. And the other thing I want to mention too is, if you ever end up with a positive TB test in the past, whether it's a year ago, 5 years ago, 10 years ago, there's no point in ever doing another one again, because it's going to come back positive. So what's the point? So if we run into a situation, one of the screening questions we always ask is, have you ever had one of these tests before? And if you had one of these tests before, did it come back positive? And if it comes back positive, it's like you're kind of wasting your time getting it done, because it'll come back positive again. And even if you were treated, it's still going to come back positive. So yeah, there's really no point in doing the test. You just need to go straight to the X-ray.
Right. And the X-ray is enough kind of to say.
Usually that would be sufficient, but that's basically what you have to do. And that's basically the the process you have to look at. But we've certainly had cases like that where it's like, we're not going to bother doing this. There's no point. And they just need to get the x-ray done up.
Right. All right. Anything else you wanted to mention?
I think that's pretty much it. TB test is really weird. One of the things I want to do, and we were talking about this at the clinic last week, about doing a video of getting a TB test done. I think might be something interesting to show people, because it is a sort of an unusual looking thing. When you get the injection, it's just under the skin, and you create like a little bleb where the liquid goes. It's kind of like one of those things that's, it's unusual and not really necessarily painful, but I think if you are watching it, you might get a little grossed out by it, I think. But yeah, it's interesting at least, and it's kind of a cool skill to have. We're quite fortunate. Most of our staff has gone through specialized TB training through the tuberculosis clinic. A few years back, the tuberculosis clinic here in Calgary was offering a program where they would help teach you not only how to do the test, but how to read the test. And it was great. It was very informative. Unfortunately, they've had some budget cutbacks and they discontinued that program, unfortunately. But it was great when we had it. I think we did it like 2016 or something like that.
Well, I'm sure that video is not the grossest thing that you could see on the internet. That's for sure.
No.
But it definitely it just seems like unique. Like you wouldn't see something like that every day. That's not how the majority of vaccines are administered. It's not how most tests for different diseases are done. So I definitely think that would be something that might be of interest to the public.
Yeah, I think we'll look at doing that. By the way, I just thought of this while we're talking. The closest thing that some people would have a level of familiarity with is allergy testing. If you've been to get an allergy test done, it's kind of similar to that. That would be the closest thing that I think some people would have experienced. That is probably the closest comparable that I could give you.
Well, I can tell you those are not very fun. And they are itchy.
Yeah, and the difference is with those allergy tests, it's like a whole bunch of things. This is just one, so it's not like you're getting a whole whack of them. It's just the single one.
Yeah, but it doesn't. In the same vein, it wouldn't hurt. It just is kind of uncomfortable.
Yeah, it's just kind of like it feels weird, and yeah, but it's not inherently painful, but it's still at the end of the day, it's a needle, I guess. So, but it's just going underneath the skin. One of the things that I tell my students, and this is I can talk about this, I guess, on here because I'm not doing it. I try not to tell patients when I'm actually in the process of doing this. But you want the needle to be so close to the top layer of skin that you should actually be able to see the needle through the skin. That's how if I can see the needle underneath the skin, you're in the right spot.
Perfect.
Yeah, that's like I said. Now maybe you know why I don't make a point of mentioning that to patients while I'm doing it.
Yeah. Anytime I get a needle, I simply just cannot look at it. So I definitely would not want to see that.
Yeah, definitely.
All right. Anyways, thanks for tuning in to this week's edition of the Polaris Travel Health Podcast. A reminder that the information and advice that we provided in this podcast are not a substitute for live medical advice that is tailored to your itinerary and your medical history. If you have questions or want to book an appointment, please head over to our website, www.polaristravelclinic.ca. Also, check us out on Twitter @PolarisTravelRx and our Facebook page as well. We hope you'll tune in again with us next week.
Thanks, Jaden.
Yeah, thank you.